Assalamu alaikum. I'm Dr. Abdul Latif Shahid, Head of Department, Pediatric Orthopedic Surgery, the Children's Hospital and University of Child Health Sciences, Lahore. Today, I'm going to discuss about pathological changes in DDH. Before going into detail of pathological changes, first of all, something about normal hip joint. Hip joint is formed between femoral head and acetabulum. Femoral head is spherical shaped and there is an angle between femoral neck and femoral shaft. Usually it is between 125 to 135 degree. There is also retroversion between femoral head and neck and femoral shaft. It is 35 to 40 degree at birth, but it decreases with the passage of time, and in adult it is usually 8 to 15 degree. Acetabulum is a socket shaped, it is deep. These two things, femoral head and acetabulum, they are actually hip joint. Femoral head resides within the acetabulum. There are also some ligaments, some cartilages, and capsule which form hip joint. One ligament is called transverse acetabular ligament. This ligament at one side connects with femoral head, while on other side it is connected with acetabulum. Transverse acetabular ligament is present infromedially in the acetabulum. There is a cartilage within the acetabulum, it is articular cartilage, it is made of hyaline cartilage. There is another cartilage present at the periphery of acetabulum. It is made of fibrocartilage, and this portion of acetabulum is called labrum. Capsule is present at one side, it is attached at the periphery of acetabulum, and on the other side it is attached to the neck of femoral head. There are also some muscles around the hip joint which helps in the movement of hip joint. Medially, adductors are present, anteriorly, flexors are present, and laterally, abductors are present. So, this is something about normal anatomy of hip joint. What are pathological changes take place in DDH? These pathological changes are divided into two types: soft tissue changes and bony changes. First of all, soft tissue changes. Soft tissue changes occur in muscles and ligaments, in capsule and within acetabular cavity. Muscles, adductor, especially adductor longus, is shortened. Flexors, especially iliopsoas, is also shortened. Ligamentum teres is hypertrophied and elongated. Transverse acetabular ligament is also hypertrophied and shortened. Capsule is expanded, hypertrophied, and elongated. Acetabular cavity is filled with fibrofatty tissue that is called pulvinar. There are also two other changes. The cartilage. One is Labrum is converted into limbus. You know, the periphery of acetabular cavity is thickened. Now, this labrum is called limbus. Within acetabular cavity, there is a formation of ridge at posterior part of acetabulum. It is called new limbus, and this new limbus is formed due to movement of femoral head within the acetabulum. This is pictorial diagram of pathological changes. Iliopsoas tendon, shortened and elongated. Ligamentum teres is hypertrophied. Transverse acetabular ligament is also hypertrophied. Acetabulum is filled with fibrofatty tissue that is called pulvinar. Labrum is called limbus. Now, bony changes. Bony changes are of two types. One, changes in acetabulum, and other changes in femoral head. Acetabulum now is shallow, oblique. There is increase in anteversion and formation of limbus and new limbus. While in femoral head, changes are femoral head is flattened, there is increase in anteversion, increase in neck shaft angle, that is coxa valga. There is also formation of false acetabulum. What is meant by false acetabulum? Femoral head resides supralaterally in the iliac wing, and there is formation of a new acetabulum that is called false acetabulum. Now, these pathological changes prevent reduction of femoral head, and hence these pathological changes are called obstacles. Obstacles are of two types: extraarticular obstacles and intraarticular obstacles. Extraarticular obstacles are of muscles, ductus longus and psoas, and intraarticular obstacles are pulvinar, ligamentum teres, transverse acetabular ligament, capsule, and limbus. During the treatment of DDH, what should be done with these obstacles for successful surgery? Regarding extraarticular obstacles, ductus longus stenotomy should be done. Psoas stenotomy should also be done. Pulvinar should be removed. Ligamentum teres should be excised. Transverse acetabular ligament should be cut, and redundant capsule should be excised. Here, one thing is very important, that is to understand the concept of limbus and new limbus. Limbus is called, the labrum is now called limbus. The new limbus is actually a ridge in posterior part of acetabulum that is developed due to repetitive movements of femoral head within the acetabulum. Limbus is obstacle, while new limbus is not an obstacle. Both limbus and new limbus should be lived as such. When femoral head is reduced within the acetabulum, with the passage of time, this new limbus resolves. Limbus again become labrum. This is called docking of femoral head. One thing is also very important, that is when femoral head is displaced superiorly and laterally, then its reduction is difficult. So sometimes we, in old children, we have to perform femoral shortening. The purpose of femoral shortening is to reduce the head easily and also to prevent avascular necrosis of femoral head. With this femoral osteotomy, we can also derotate to correct retroversion, and we can also perform varus to correct valgus deformity. Regarding acetabulum, increase the coverage of femoral head after its reduction, pelvic osteotomy is required. So, in a nutshell, there are two types of pathological changes: soft tissue changes and bony changes, and there are two types of obstacles: intra-articular obstacles and extra-articular obstacles. These obstacles should be wisely dealt for successful outcome of DDH surgery.